So welcome everyone to the 10th installment of the Best Practices for Clinical Care in the World Trade Center Health Program. Today's topic is smoking cessation, and today's webinar will be presented by myself. I'm Jeffrey Calvert, the Associate Director for Clinical Quality at the World Trade Center Health Program, and I am joined today by my esteemed colleague, Dr. Sandra Lowe, who's the Medical Director of the World Trade Center Mental Health Program, as well as an Associate Professor in the Departments of Psychiatry and Environmental Medicine and Public Health at the Icahn School of Medicine at Mount Sinai. So a disclaimer is the views expressed in this presentation are those of the authors and not necessarily those of CDC and NIOSH. In addition, any trade names, practices, organizations, websites that we mention are not necessarily endorsed by CDC NIOSH, and CDC NIOSH is responsible only for the content on its own website. Also, we have one minor disclosure to disclose, and that's listed on this slide, which has been mitigated. This is the outline for our talk, so I'll provide a background on smoking and tobacco. I'll discuss reasons to quit smoking. We'll explain why it's difficult to quit. Then we'll go into a case presentation, and we'll actually refer to that, kind of weave that case presentation in through the course of the webinar. Next, we'll talk about treatment in both pharmacotherapy as well as behavioral interventions. We'll talk about lapse and relapse. Then we'll do a conclusion and then open it up to questions. So by way of background, so when we refer to tobacco in this talk, we'll be referring to commercial tobacco and not to the sacred and traditional use of tobacco by some American Indian communities. And as I was preparing this talk, I learned that the tobacco plant actually is indigenous to South America. And so it's been used by the indigenous communities in the Americas for thousands of years, so millennia. It was brought to North America thousands of years ago, so it's been used for a long time. In contrast, throughout the rest of the world wasn't introduced to tobacco until the Americas were discovered in 1492. And then the other thing I learned is that the indigenous populations apparently were the ones to discover that the lungs could be used for another item. So in addition to respiration, the lungs could also be used for stimulation. So I don't think other civilizations or populations had discovered that until the indigenous communities on the Americas. So this chart shows cigarette consumption from 1900 to 2020. And again, this is cigarettes. So keep in mind, cigarettes, I think they were discovered or first produced back in the early 1800s. So even you see here in 1900, this is showing per capita number of cigarettes smoked per year. So basically, average number of cigarettes smoked per person in a population. So in 1900, the cigarette consumption was pretty low and didn't peak until around the 1960s. Generally, that increase was commonly associated with our entry into the world wars, World War I and World War II. And then use finally started to decline into the 1960s and 1970s, beginning with the Surgeon General's report on smoking and health, which made the connection between cancer and smoking. Then there was also the broadcast ad ban, so no advertising on TV. Also, cigarette tax, the federal cigarette tax doubled in the mid 70s. The other interesting point is cigarette is a French word, so it's considered one of the most common French words used in the English language. So even though tobacco use, according to that chart I just showed, has dramatically dropped, it's still common in our population. So you can see here on the left, about almost 19% of the population currently smokes, and this is as of 2021. So that's 46 million adults. Most of the people who smoke cigarettes, but there's not a trivial number of Americans who also use e-cigarettes cigars, smokeless tobacco, and pipes. And smoking prevalence is even higher among individuals with mental health conditions. So you can see that on the top bar, almost 14% of the population who don't have mental health conditions smoke, and that doubles among people who have a mental health condition or mental illness. And it's even higher among people with serious mental illnesses. And I don't have it listed on this slide, but if you look at people with other substance use disorders, so actually tobacco use disorder is a substance use disorder, but if you look at people who have another substance use problem, for example, alcohol, opiates, they're even more likely to also be smokers. It's between 60 and 90% of those individuals with other substance use disorders also smoke. And smoking affects nearly every organ system in the body. I probably don't need to tell you that, but on the left, you can see all of the cancers that are caused by smoking. And on the right, you can see the chronic diseases, so the non-malignant diseases that are also caused by smoking. So I'm not going to go into each one. We don't have time for that, but you'll see that. So there's good evidence for all of these diseases being caused by smoking. So smoking or tobacco use is the leading preventable cause of disease, disability, and death in the US. And if you're going to take the post-test, that's something to keep in mind. Tobacco is responsible for 1/3 of all cancer deaths in our country. And there is no safe level of tobacco consumption. So even like if you smoke 1 cigarette per day, that's not safe. So why quit smoking? So there's many motivations to stop smoking, including becoming aware of the health consequences of smoking. Many people who decide to stop smoking do so when they become diagnosed with a medical condition caused by smoking. At that point, they realize maybe it's, this is not a good habit. I better quit. Also, women who become pregnant realize it, are motivated to quit smoking. There might be restrictions at work or in the community. And that was probably especially true 10 years ago when those restrictions began to manifest. Also, people might be worried about exposing their children and grandchildren. Could be concerned about physical attractiveness since smoking ages the skin prematurely. Also, hygiene reasons, given smokers have a certain kind of odor about them. Also, people who want to compete in sports realize that they could have a competitive advantage if they quit smoking. Probably endurance would be better. And then there's the cost, both in terms of just the cost of cigarettes being very high, especially with the taxes, in addition to health insurance premiums also being higher often in smokers. And then the benefits of quitting are that it can reduce the risk of smoking-related diseases, or even if a person has a smoking-related disease, it can reduce the severity of that disease. So even people with a cancer, if they quit smoking, their survival from that cancer is improved by quitting smoking. So it's never too late to quit. The earlier you quit, the better for your health, but it's never too late. Other benefits of quitting are to save money, save time, and also by quitting, you set an example for others. So people can point to that person who quit and say, look, he did it. I could probably do it too. And then for people who have psychiatric conditions, there are additional reasons for them to quit in terms of it. By quitting, it reduces their depressive symptoms. It also allows for more consistent dosing of psychiatric medications because tobacco use induces enzymes that metabolize those medications. And also, treatment of this tobacco use disorder increases the success of treating other drugs in persons with other substance use disorders. So those individuals, by quitting smoking, they often learn non-drug ways to cope with stress and learn ways to avoid cue-based triggers, which also can be used when quitting other substances. Excuse me. So among smokers, most of them actually do want to quit smoking. So 2 out of 3 smokers want to quit. Half of them actually make a quit attempt each year, but only 1 in 11 are successful in quitting. So why is it difficult to quit? So nicotine is actually one of the most difficult addictions to overcome. So the cigarette companies that actually make these products actually design them to have a rapid onset, very rapid onset, and a very intense onset. So it's basically the nicotine when you smoke, it's freebased directly to the brain. And with each inhalation, nicotine is absorbed into the arterial blood, and within a heartbeat, that blood is going to the brain. So it's just a very intense and very rapid effect, which is difficult to overcome. And you know, with smoking, it also basically changes the chemistry in the brain. So you develop more receptors, more of the nicotine receptors in the brain, which also makes it difficult to quit smoking, especially doing it cold turkey on your own. And then other reasons that it's difficult to quit is that nicotine becomes linked to mood states, becomes linked to environmental cues. There's craving triggers, including having coffee or a cocktail, getting into the car, passing certain geographic locations, hearing certain sounds, all can trigger the need or the desire to have a cigarette. Then there's also the olfactory triggers, which are very primitive and powerful to the human brain. So those olfactory triggers could be cigarette smells, the coffee that you drink. You're used to having a cigarette when you drink your coffee. So that trigger can be very difficult to overcome. And then the cues are reinforced very frequently during the day. So imagine a person who smokes a pack a day, takes 10 puffs on each cigarette. So they're basically taking their fingers to their lips 200 to 250 times per day. So that's a very common activity, very common kind of ritual that's difficult to overcome. So now I'm going to pass the baton to Dr. Lowe, who's going to present a case of a person with tobacco use disorder. Take it away, Dr. Lowe.
Thank you, Dr. Calvert. So given the severity of the health consequences associated with tobacco use, all clinicians, all of us share a responsibility to educate our patients and to really help them to quit tobacco. We realize how hard it is. So I'm going to briefly describe a model that was developed for primary care providers to help guide them through the process of helping patients quit. And I'll also go through a composite case of a World Trade Center responder to demonstrate how it is applied. So the model, it is called the 5A's model, and it is the gold standard for management of tobacco use disorder. And what it does is that it incorporates screening, treatment, and referral, which is a very common practice. So it can really be completed in about 10 minutes if that's all the time that you have. However, if you have additional time, of course, it's going to be helpful in being able to individualize it a little bit more. I'll take you through it on a just high level at this point before applying it to the case presentation. It all starts with asking about tobacco use. And you need to ask all patients about current tobacco use. If they're not currently smoking, great. But also ask about prior use or recent quitting, because at that point you can also assess whether the individual may need additional support to maintain their abstinence. Now, if the patient is using tobacco, this is a time where you provide a message of advice to quit. It can be very brief and personalized, and attaching it to their clinical presentation really makes a difference. If the answer is no, that's fine. Just leave the door open and make sure that you ask next time. However, if the patient expresses some interest in quitting, the next step is to follow with an assessment of their readiness to make a quit attempt. So some people will be ambivalent, and that's where motivational interviewing comes into play. And unfortunately, I won't have time to go into that, but there are a lot of online resources on techniques for motivational interviewing. If the patient is at the level of motivation where they're willing to make a quit attempt, the next step is to get an assessment of prior smoking history, prior quit attempts, and what has worked, what hasn't worked. And if time allows, getting an idea of what some of the barriers have been to quitting. Now, this brief assessment gives you a starting point for what to do next, which is to assist with the quit attempt. And this is where the treatment comes in. So you develop a treatment plan that includes education, counseling, you establish a quit date, you prescribe medication, if that's a step that the patient is agreeing to, and behavioral treatment planning. And the last step, the step to arrange, is critical because making sure that a patient has a follow-up appointment with you or with someone else who's going to continue the treatment makes a big difference in success in quitting attempts. So this is a patient whom I saw several years ago. Peter was a 62-year-old man who had recently retired as a Con Ed gas mechanic, and he had worked at the World Trade Center site surveying for gas leaks. And he was living with his long-term partner at the time. His certified conditions included asthma, and he noted that his symptoms had been worsening over the past few months, even though he had been taking his medication as prescribed. He also had been certified with alcohol use disorder, and fortunately had been in remission for the past 2 years. He also had been in treatment in the past for post-traumatic stress disorder, PTSD, not actively in treatment, and he had minimal symptoms. And of course, he has tobacco use disorder. So the first step is I asked him about current smoking. And yes, he said he was smoking about a pack and a half a day, and that it actually had increased since retiring about 3 months ago. So I then advised him to quit, saying, look, you've increased to a pack and a half. You're mentioning your worsening respiratory symptoms. This is connected. This is a good opportunity to quit, and I can help you in doing so. So then we move into the assessment part of it. So clearly he's motivated. We know what his motivator is. I obtained the tobacco use history. He had a 50-pack-year history of cigarette smoking. There were no other tobacco products that he had used. And he had made many quit attempts and minimal treatment. And the many quit attempts speaks well about his desire to eventually quit. He had tried going cold turkey, which he said was terrible and would never do again. His longest period of abstinence actually was for about a month with the nicotine patch. That's important to note. He had tried e-cigarettes, which he didn't like. And by the way, that is not a recommended technique for smoking cessation. And he had also tried varenicline, a 4-week trial. This had been prescribed by his pulmonologist in the past year. And the plan was that the patient was going to take the 4-week starter pack and then call the pulmonologist to get the next prescription. However, his next appointment with the pulmonologist was in 6 months. So Peter tried it for 4 weeks. He didn't feel that it was making any difference. And at that point, just didn't pursue it. And of note, he had not had any smoking cessation counseling. So at that point, you actually can stop there, and you have enough information to actually create a treatment plan for Peter. However, I did have extra time, so I took the opportunity to ask some questions about what are his reasons for smoking. Well, he said that he enjoys his first cigarette and with his morning coffee. That's how he starts smoking. He sits there with his partner in the kitchen, and it's a nice time. His neighbors also smoke, and those are the people he spends most of the time with. Since retirement, he's been spending more time at home, and without the smoking restrictions at work, he's been smoking more. And he also uses the smoking for stress and boredom relief. I asked him about what was making it difficult. What are the challenges that he perceives? Well, he says his partner smokes at home. She smokes a lot, therefore it's impossible for him to quit. He also mentioned having cravings and withdrawals, and retirement had not been that easy. It was pretty stressful, so that was part of his smoking more. And interestingly, he mentioned that he feared that if he tried quitting smoking again, he might have a recurrence of more severe PTSD symptoms. And that's because when he had tried quitting in the past, he had experienced symptoms like irritability and anger, restlessness, feeling on edge, and feeling down and in a funk. So were these withdrawal symptoms or PTSD symptoms? We don't know. Probably both, because they clearly do overlap. Okay, so what do I know about at this point about Peter? He's motivated, insightful. He's been abstinent from alcohol, which is a real plus. He goes to his medical appointments and is adherent with his medication. However, he does have a severe addiction, environmental triggers right in his home, and he does have PTSD, a diagnosis of PTSD and alcohol use disorder. And that's important to recognize because there is substantial evidence that individuals with PTSD or trauma disorders are more likely to use tobacco products and less likely to abstain even when they are provided with the classic smoking cessation treatments compared to individuals who don't have a history of trauma. And the most commonly cited reason for people with PTSD for smoking is that they say that they use it to manage their PTSD symptoms. So important. The other element that I learned, of course, was that he's had no effective treatment. So at this point, I'm able to provide him with the next step, which is assisting him, provided education about nicotine withdrawal and overlap with trauma symptoms, noting that it's common to use tobacco to self-medicate. And even though he was motivated, I could also add some motivational enhancement, acknowledging the difficulty and his many attempts. I focused on his motivator to improve his breathing when discussing the benefits of quitting. I acknowledged his ability to abstain from alcohol, which is also difficult to do, and highlighted that in previous attempts, he had no medication or counseling, and that in getting that, it would significantly increase his chances of being able to quit. So continuing the assist plan, I had a recommended treatment plan. We set some goals to reduce smoking, eventual abstinence. I recommended a quit date in 6 weeks. I recommended varenicline and a nicotine replacement therapy, went over the proper use, and counseled him. And some of the coping strategies that it's important to have something personalized. So some of the coping strategies that I mentioned are, ask your partner to smoke it outside and make yourself responsible for making sure there are no cigarettes or ashtrays in the common areas, and that he really needed to do that. The other thing was that he had mentioned that he started his day smoking with that coffee in the morning in the kitchen. So I advised them, try separating it. Go ahead and have your coffee with your partner in the kitchen, but then both of you go outside to have your first cigarette, trying to disassociate those cues. And I also said, look how retirement has impacted you. So I advised more structure and getting some outdoor activity. So at this point, I'm going to turn it back to Dr. Calvert, and then we'll come back to Peter and see how what the next steps of his treatment were.
Thank you, Dr. Lowe. So a few disclaimers on treatment. So there is no one-size-fits-all treatment for tobacco use disorder. Each patient is different. So it's important to, as Dr. Lowe was mentioning in her case presentation, to discuss with the patient, to do shared decision-making, offer what the options are to the patient, explain the options, and help the patient to decide which options to choose. There are 3 clinical practice guidelines. Actually, there's more than 3, but I've got 3 of them listed here. One is the Surgeon General's report. That's the first one, U.S. Public Health Service 2008 update. It's relatively old. It's 16 years old, but still very relevant, still has very useful information. And it's basically the most comprehensive source still. There's also the U.S. Preventive Services Task Force from 2021 discussing the importance of interventions for tobacco smoking cessation, especially in pregnant persons. And then there's the American Thoracic Society Clinical Practice Guideline from 2020, which discusses initiating pharmacologic treatment in tobacco-dependent adults. And actually that third one, American Thoracic Society, will be actually several of the subsequent slides will be focusing on that clinical practice guideline. And the other thing to note is that Dr. David Prezan is a co-author of that third publication. And as you know, he's a very prominent person in our community within the World Trade Center Health Program. So we can't overemphasize the importance of combining medications with counseling. So Dr. Loeb mentioned that. And so I just wanted to mention it here too, that the greatest chances of success in smoking cessation is when you combine medications plus the counseling. Very important. So oftentimes patients are prescribed the medications, but the counseling is ignored. But it's just so much more effective if you combine both counseling and medication. So other general treatment guidelines are the more aggressive you treat the nicotine withdrawal, the better the outcome's going to be. Often combinations of medications are recommended. So in the case that Dr. Lowe just presented, she was combining varenicline plus the nicotine replacement therapy. So that's a recommendation to combine medications. You don't always need to. Oftentimes you start with just one medication, but many times you need to combine medications, and that's okay. And then you need to keep in mind that when a patient's quitting smoking, that there's 2 things that they're battling with. So one is the pharmacologic effects of the nicotine, just the withdrawal effects. And then there's the condition cues associated with that tobacco use. For example, in our case, he associated drinking coffee with smoking, and he needs to kind of break that association. So moving into pharmacotherapy, these are the 7 medications that are FDA approved for smoking cessation. So you'll see that 5 of them are nicotine replacement therapy. And out of the 5, 1 is the controller medication, the patch. You slap that on, and it basically provides a continuous form of treatment throughout the day. And that's considered a controller medication. Basically, you've got that medication on board throughout the day. Then there's also 4 reliever medications, which are used short-term when a patient has a craving or acute withdrawal symptoms, they could use one of these more fast-acting types of nicotine replacement therapy. And the reason I have the oral inhaler kind of shaded out is because although that is FDA approved, it's no longer being manufactured. So it's going to be probably difficult to find that on the market. So that's why that one's shaded out. And then I've also got two oral medications that are also FDA approved, which are also controller medications. That's bupropion and varenicline. And I'll talk a little bit more about those in subsequent slides. And for each of these medications, there's actually, I think nasal spray is the only one that doesn't have different dosages, but all the other ones come in a variety of dosages. So basically for example, for cigarette smoker, the more cigarettes they smoke, the higher the dose that you want to use with these medications. So the mechanism of action, basically all of these medications are going to be focused on that nicotine receptor. So basically what they're doing is sitting on that nicotine receptor, and by the medication sitting on that receptor, and it's not as strong a activator of that receptor, by sitting on that receptor, it's blocking the nicotine from tobacco, from smoking or other tobacco products from interacting with that receptor. So basically, these medications are blocking that receptor and preventing the effects of nicotine from smoking. So varenicline, that's the way it works. Bupropion, it's an antidepressant, also used in smoking cessation, and actually one of the kind of quote unquote side effects when they were doing clinical trials on bupropion was that the people who were taking it said, hey, you know, I seem to have less of a desire to smoke when I'm on this medication. So that kind of led to it being used for smoking cessation. And then with nicotine replacement, again, you're replacing the nicotine from these medications with the nicotine from tobacco. But with the nicotine replacement therapy, the effects aren't as quick acting, so that, and they're not as intense as what you get when you smoke a cigarette. And again, so they're sitting on that receptor, so that when people do smoke, when they're taking the nicotine replacement therapy or one of the other two medications, a person, when they smoke, they just don't have the same enjoyment from that smoking. So that then makes it easier for them to quit the smoking. So I'm going to talk a little more in depth about these American Thoracic Society recommendations for initiating treatment. So I'm going to just mention all 5 of them here on this slide, and then I have a separate slide for each one of these. So one is that varenicline is recommended over bupropion or the nicotine patch. Also, the varenicline plus the nicotine patch is recommended versus varenicline alone. Varenicline is recommended in smokers not ready to quit. Varenicline is recommended in smokers with psychiatric conditions. And then extended duration of treatment is often needed. And when it's needed, that is recommended. So going first to the varenicline versus the nicotine patch, again, when initiating treatment, ATS recommends to go with varenicline. And you can see in this table, and you're going to see this table in the next several slides, it's the same, going to be in the same format, same rows. So the first row is the abstinence during treatment at 10 to 12 weeks. And you can see that varenicline is much more effective with abstinence at 10 to 12 weeks compared to the nicotine patch. And likewise, abstinence at 6 months is higher with varenicline. So this is the reason why ATS recommends varenicline over the nicotine patch. Same thing with bupropion. Again, when initiating treatment, varenicline is going to be more successful than bupropion. And you can see again in that table, abstinence at 10 to 12 weeks and abstinence at 6 months is greater with varenicline compared to bupropion. And the incidence of significant adverse effects were similar for both of those drugs. So that's not a reason to choose one or the other. And then in terms of combining varenicline with a nicotine patch versus using varenicline alone, this is the one recommendation where it was conditional because it's not based on really good evidence, but nonetheless, it is recommended if possible by the ATS. But ATS also recognizes that initiating 2 medications is more difficult than taking 1 medication. So by 2 medications, it's more complicated. It's easier to just take 1 medication. Although you would think, with a patch, you're generally just slapping on 1 patch per day. But nonetheless, you may, if you think the patient can tolerate it, you could try the 2 medications. And again, you can see the dramatic improvement in abstinence in this table when you combine both of those medications. In terms of recommendations for those not ready to quit, so it's recommended that varenicline be used in those individuals. So you saw on one of the earlier slides that 2/3 of smokers are interested in quitting, but only half of smokers actually do attempt to quit in a given year. So by giving them varenicline, those people who are interested, it could actually motivate them to actually want to try a quit attempt. Because remember, having the varenicline on board is going to saturate those receptors, those nicotine receptors in the brain. The patient's probably going to be smoking less cigarettes when they're taking varenicline and may have the motivation to actually undergo a quit attempt. So in terms of how long do you keep a patient on varenicline who hasn't initiated a quit attempt, that remains to be determined. But generally, if the patient hasn't begun to quit within 6 to 12 months, probably you should take them off the varenicline. In terms of varenicline use in individuals with psychiatric conditions, as you may recall, up until 2016, there was a black box warning on the varenicline package, a warning about serious neuropsychiatric effects. But that black box was removed in 2016 because it was determined that the neuropsychiatric effects were no greater with varenicline compared to any other smoking cessation medication. But nonetheless, some people may remember that. They may be hesitant to use varenicline. So these individuals with psychiatric conditions need to be told that the truth and that there really aren't any more increased risks of serious psychiatric events or neuropsychiatric events. And as you can see, among people with psychiatric conditions, the success with varenicline is much greater compared to the success with nicotine patch. And then in terms of extended duration, so many patients, so like for varenicline, the FDA label says that the treatment should be for 12 weeks, and then if needed, you can extend it for another 12 weeks, but it doesn't say anything about what to do after that 24-week period. So ATS recommends that if the patient still needs these controller medications after 24 weeks, it's fine to leave them on these controller medications. And this is recommended not only for varenicline, but also for bupropion and for nicotine replacement therapy. So it's considered to be cost effective. And you have to remember that taking these medications is a lot safer than the patient actually smoking. So just the risk benefits are so much greater with using these medications compared to smoking. And now I am going to pass the baton back to my good colleague, Dr. Lowe.
Thank you. So this is just a reminder that counseling plus medication is considered optimal for success in smoking cessation. So when it comes to behavioral interventions, there is high certainty evidence that providing behavioral support to people using smoking cessation medication is going to increase quit rates. That's been replicated many times. That is quite clear. So the combination treatment is preferred. It also appears that dosing matters, that is, increasing the number or the duration of sessions focused on behavioral interventions increases success. Now, for providers who are directly delivering the smoking cessation treatment, providing the motivational interviewing, health advice, counseling. There are realistic time constraints. So increasing the dosing, it just may not be feasible. Fortunately, there are a lot of effective ways to extend support outside of sessions, and that brings us to the quit lines and mobile or digital help. Now, there are so many resources out there right now. It's quite wonderful. And these here are some that you can provide to patients. Let me just highlight the quit line, the 1-800-QUIT-NOW. The quit lines are available in all states in multiple languages, and they are free of charge. And they offer confidential, tailored counseling from trained coaches who are really good, who can help with the quit plan and also provide support throughout the process. Some quit lines even offer starter kits of medications, as well as teaching them how to use them properly. And while telephone support is the most common, there are a number of web-based and digital interventions that have also been, that can also be successful. So one of them is the Quit Now from smokefree.gov. The mobile app is called Quick Start. There is Help Me Quit. Those are both really good. Some patients prefer them. I also want to draw your attention to the smokefree.gov website. It is really excellent. I suggest you take a look at it before you're recommending it to patients so that you know what you can draw their attention to. And Build My Quit Plan is one of my favorites. It actually is a really well-organized, planned, individualized program that patients can use and have used very successfully. Now, that is a lot of support. However, we do know that some individuals do better with more intensive or longer treatment. So you need to consider referral to intensive behavioral therapy. And that's something to consider in patients who ask for therapy as part of their cessation treatment, or for patients who have been unsuccessful despite prior quit efforts. And certainly for those who have complex presentations, multi-comorbidities, acute or chronic stressors, lack of social support. But I'll also acknowledge a clear barrier, and that is availability of counselors and therapists who are trained. And very briefly, I'm going to mention that cognitive behavioral therapy is what is most commonly used as in this intensive behavioral therapy. And this is an evidence-based psychotherapy that's been effective in many conditions, and including addiction treatment. And at the core, the goal is to identify and change destructive thought patterns and behaviors. It is goal-oriented, structured. It can be delivered individually or in groups. It is 6 to 12 sessions, and focuses on skills training, such as practicing deep breathing, yoga, and mindfulness, the sorts of things that you're not going to have time for in routine visits. One very helpful thing that it adds is helping people through role play and rehearsing how to respond to social situations that may trigger smoking. And ultimately, what you want to do is to enhance self-efficacy. You want to teach people to be able to do this on their own, because smoking cessation is for many a long-term process. So back to Peter, where we left off. Was developing a treatment plan. And I had made some suggestions, including varenicline and NRT. I had recommended mental health services and a quit date in 6 weeks. However, being collaborative makes a really big difference. The process of shared decision making is going to increase engagement, adherence, and rates of success. Peter wanted to set a quit date in 3 weeks. He did not want varenicline, but he agreed to the patch and the gum. He really liked the quit line idea, and I had him download the app before he left the office, and made an appointment in a month, and he agreed to regular follow-up. So what happened? He didn't come back in 4 weeks for his appointment. He did return 8 weeks later, and he had felt really embarrassed, feeling that he had failed. And this is an opportunity. You're going to face this a lot when you're helping people quit smoking. It's an opportunity to be supportive and non-judgmental. It's really hard to quit. And also to note where gains have been made. He had been able to reduce his smoking to less than a pack per day, and he had continued using the nicotine replacement therapy. So I asked him about what were the barriers. He still had a lot of cravings, and he blamed his partner. There's cigarettes everywhere. She won't smoke outdoors. And there was also the concern that he had about these symptoms, which could be withdrawal or PTSD symptoms. So we discussed an improved plan based on that. I strongly suggested adding varenicline to NRT, and he agreed this time. And schedule the next 2 visits. Sometimes having visits on the schedule is going to encourage people showing up. I invited bring his partner so that we can involve her in the plans. And I said, let's set a quit date in 6 weeks. Let's let the medication take effect. And I also said, I'm going to give you a call before your quit date, just to check in and see how things are going. And again, I think it would be helpful for you to take a mental health referral, which he declined again. Subsequent visits, he further reduced smoking. He didn't quit in 6 weeks, which is fine. But at 3 months, he was abstinent, and I asked him what had helped. Medication made a big difference for him. He was also less worried about PTSD relapse because he didn't have these withdrawal symptoms. He loved the quit line, and he was making good use of it. And his breathing had improved, which is where this all started. And he had been playing golf with a friend, which is wonderful. So we kept the plan going that was working. And I did discuss the possibility of lapsing and advised him to continue the medication, even if he does slip, which brings us into lapses and relapses. So it's really important to understand that tobacco use disorder is a chronic relapsing medical condition. Healthcare providers need to realize that. And providers also need to prepare patients, letting them know that quitting smoking is a process. In all likelihood, it'll require multiple attempts. And I have no problem saying relapse is, after initial success, is pretty much the norm for most people. It's not going to encourage them to smoke. But I also add that it doesn't mean that you're starting from the beginning each time. For providers, it's important to take a look at what's contributing to relapse. And very often it's that the treatment, whether it's medication or behavioral therapy, is not optimized. Of course, there can also be things outside of your control, stressors, medical and psychiatric problems, and some individuals may need a higher level of care. Peter was doing well up until it was actually more than a year later when he relapsed. He had been smoking half a pack a day for 2 months. And what occurred was that his golf buddy, who was also a responder, was diagnosed with cancer, and he had started to feel bad, down, anxious, isolating, and he was also craving alcohol. So again, an opportunity to validate the feelings. It's sad. This was his buddy who had cancer, And also for our population who have have World Trade Center exposure, there is always the looming fear that they're also going to get cancer. So it's very stressful. And also, remember that people tend to feel shame when they relapse. I highlighted to Peter that I really thought that what was happening was that he was self-medicating at this point. And my advice at this point was to re-implement the plan that worked and strongly recommend intensive behavioral therapy. And he agreed, and I arranged a visit before we left the office. So Peter completed 8 sessions of cognitive behavioral therapy, was able to address some of the acute stressors and learn management skills for PTSD and alcohol use symptoms. And his partner joined him for a couples therapy, which was great. Outcome is that for almost 3 years now, he's had sustained abstinence. So I will end by saying, make sure that you're engaging, learn how to do this. Make sure that you're engaging your patients. Anticipate that there are going to be relapses, but do not give up. Keep on trying. And with that, I will turn it over to Dr. Calvert.
Thank you, Dr. Lowe. So we're at the conclusion. So as we mentioned during this talk, all healthcare providers should assess tobacco use disorder and offer interventions when patients with tobacco use disorder are identified. Nicotine is one of the most difficult drugs to quit. Often you need to increase treatment intensity when less intense treatment is ineffective. And keep in mind, tobacco dependence is a chronic relapsing condition that often requires multiple interventions, quit attempts, and long-term support. So it's not a habit or a lifestyle, but it's a chronic medical condition that needs support, needs our support. So I wanted to acknowledge all of the people who have helped out with today's webinar, as well as the whole webinar series. And actually, if you look in the chat, there is links to the recordings of our previous webinars, as well as links to the articles as part of this webinar series or clinical best practices series. And we have time for questions. We have a few minutes, maybe like 5 minutes, I think, Anne, for questions.
Sounds good. Thank you, Dr. Calvert and Dr. Lowe. Our first question is, are there any side effects to the prescription medications, and can it affect prescriptions a person may be already taking, like for heart medication?
So yes, there are side effects to these medications. They do have, in addition to agonist effects on the nicotine receptors, they also have antagonistic effects. So they can produce symptoms like nausea. They can produce maybe some dizziness. So there definitely are some side effects with these medications. So I think with these medications, if a patient is having a lot of side effects with a given medication, it doesn't hurt then to take them off that medication and try a different one. And then what was the interactions with other medications? Is that what?
Yeah, can it affect prescriptions a person may already be taking, like heart medications?
That I don't know off the top of my head. That one you would have to look at the label with the medications. Dr. Lowe, do you know?
Yeah,
Okay.
I will add
Thank you.
that, especially with our patients, most of my patients are on a tremendous number of medications because they have a lot of comorbidities. So I always have to look it up, frankly, because I'm not familiar with all the cardiac meds or the pulmonary meds. So I just look it up to see if there are any interactions. Sometimes I have to adjust the dosing. It may not be an absolute contraindication, but there may be some interaction where the serum level is elevated or decreased. So yes, there's a possibility, although it is pretty uncommon.
Thank you. And then our second question, when you are taking the medications, do you decrease the dosage over time?
So when you initially take a lot of these medications, you're going to increase the dosage. So like for varenicline, I think it's the first 3 days, you take a relatively low dose, bump it up again 3 days for the next 3 days, and then go on a more steady state dose for generally up to, as I mentioned, the first course of treatment could be up to 12 weeks, and you can extend that. But when the patient feels like they don't need it anymore, you could, definitely taper the medication over time to gently take them off of those drugs. So maybe reduce, they're going to reduce the short-acting nicotine replacement therapy, like the gum, using less gum, using fewer lozenges. Sometimes people need to take more than one patch. If they're taking more than one patch, they could, at a certain point, remove one of the patches. So I don't think there's like a set in stone way to reduce these medications. Dr. Lowe, did you have anything you wanted to add?
I'll just add that in general, I'm a proponent of tapering medications in order to reduce any discontinuation symptoms that may occur. However, for example, with something like bupropion, there is a therapeutic dose that is used for smoking cessation. So if the plan is to discontinue the medication, yes, taper it, but don't leave them on a subtherapeutic dose. That's not going to be useful at all. So if you're planning on tapering, taper and then stop, and then assess to see if you need to resume, but don't leave people on subtherapeutic dosing.
Thank you.
Thank you. So, Anne, we might have time for one more question.
Okay. What are some of the common World Trade Center certifiable medical conditions that increase health risks for people with TUD? Thank you.
Dr. Lowe, do you want to take that one?
Sure. All psychiatric diagnoses are associated with an increased risk of tobacco use disorder, and also the addiction tends to be more severe and more refractory to treatment. So when you have a patient who has a psychiatric diagnosis, you really need to be very attentive to that when you are addressing their tobacco use disorder.
Thank you.
All right, so let's go into how to claim your continuing education credits. So we are offering continuing education credits for pretty much all health professional specialties: nurses, physicians, pharmacists, public health professionals. So to claim those credits, you need to go to the train.org website. And if you haven't registered ever on that site, you'll need to register. So what I would do is, if you're going to claim CE credits, take a screenshot of this slide, because it's a little complicated to get these credits. So you'll need to go to that website, and then once you're on the website, you're logged in, you'll need to type in the code WC4740, and if you're looking at the recording, you'll type in WD4740, and then once you do that, you'll find the course for smoking cessation, and then it's going to ask you for the registration code, which is going to be the WTCHP. Type that in, and then you should be registered. Then you'll be asked to take a post-test. It's 4 questions. You need to get at least 3 of the questions correct. You'll have 2 chances to do that. And then they'll ask you to evaluate the webinar. So you have it for a month till the middle of September to claim credits for this live webinar. But to get credits for the recording, you have at least 2 years, and it will probably renew that. So you'll have a total of 4 years to get credit from the recording. And so good luck with that. Let us know if you have any difficulties, any questions with getting the continuing education credit. And I think that is it. It's 1 o'clock. Thank you for your time, and wish you a great rest of your day.
Thank you,
Goodbye.
everyone.